Good evening, everyone. I'm the Chief Technology Officer and one of the founders of RightCare Solutions. The company was conceived within a mile of where we are right now. So at the Wharton Executive MBA program, we kind of put the business plan together, and before we knew, we were the grand prize winner. And when I went and rang the NASDAQ closing bell and all of that, and before you know, we had funding and we are doing this. So it's been an amazing journey. Prior to this, I've done a few startups, 4 to be precise. 2 of them technology product startups, another one in healthcare, and another consulting startup in my background. I'm a technologist at heart who dabbles in business a little bit, from the theme perspective, I would like to kind of focus on the technology and maybe a little bit detail around the product and what makes it different and new and exciting, so we can kind of focus on the tech aspects of things. So this is an industry-specific product for the healthcare industry. And how many in the audience are from the healthcare side of things? Show of hands. Okay, a few. So you will understand a fair bit of what I'm talking about here. Also, how many software technologists, especially .NET platform specialists in the audience? Okay, great. So we are building a great company and a great place to work at. So just a little plug there for myself, for my team. So the first thing is, what is the problem that we are trying to solve? And I would start it with saying that the healthcare business models are changing as we speak, from more of a fee-for-service based to fee-for-value models. And what that really means that, previously in a hospital, you go and get a surgery done, and the hospital gets paid for that surgery, an amount for that surgery. And if you have to get readmitted into the hospital because of complication that happened because of something that happened either after the discharge or in the hospital gets paid again. That's changing quickly, and that's to control the cost, but also it's a proxy for quality. If the hospital is not taking good care of the patients, they're coming back, and they're coming back quickly, within 30 days or whatever your metrics around timing are. And so what's changing is that now hospitals more and more are being paid. First, they're getting penalized for readmissions into hospitals, especially the preventable ones, as they may be. But more importantly, they're getting into more of a bundled payment programs where they're only getting paid for a specific procedure that happens. And if there are complications that happen in the hospital or outside, the hospital ends up paying or just kind of taking the burden of that extra complication. So they get paid lump sum, what they call bundle payments, and this is really changing the way hospitals operate. So once you go from a fee-for-service model to a bundle payment model, the only way you're going to save money is by focusing on quality, reducing readmissions, and becoming more operationally efficient. And that's what is happening in the healthcare industry. And if you're aware of the what percentage of the GDP goes towards in the U.S. goes towards healthcare, it's a huge percentage, by far the largest in the world. And the curve is going so far up that before we know, will be 20% of GDP on healthcare. So it'll make us bankrupt as a country. And this is a huge problem. And CMS, as the biggest payer, is attacking this problem by a carrot and sticks approach. But before all of this happened, a professor at UPenn School of Nursing, Dr. Kathy Bowles, was looking at this from a quality perspective and why are patients coming back with complications perspective. And that's the why. And over 10 years, over $5 million of NIH grant, she honed in on what are the factors that cause these readmissions and what are the factors that could possibly predict on a very evidence-centric model where you actually run experiments to be able to predict which patients are high risk for readmission when they're walking in through the door of the hospital. So, thinking about operational efficiency, if you can do that, that is tremendous, because if you say 30% of the patients that walk in through my door every day, these are the ones that I should be paying more attention to, that makes you more operationally efficient. So that's the thing about Kathy and her research, over 10 years of research. And this is what is exciting. This is the coming together of technology, predictive modeling, and also evidence-based methods that are generally only used in academic settings, by bringing that to actually build a technology that will help solve this problem. So 3 of us at UPenn, at Wharton School for our executive MBA degrees, we thought this was tremendous, and we took that technology and we operationalized it, built it into a product. So, but we didn't stop it there. We didn't say a risk stratification platform that allows you to see which patients are at high risk is enough, because now you have to actually put it in the hands of the users that are using it, such as the case managers in the hospitals that are actually responsible for care coordination. And as the hospitals are being made responsible for this patient's health, even when the patient is outside of the hospital, when they're at home or when they're at a nursing home, and being penalized for what happens in those settings, hospitals don't have the platforms, the technology, the wherewithal to actually do something about it. So, some of them are saying, I'm getting penalized, but I'm making some money on these patients that are coming back. But that is slowly being changed by CMS through their payment model reforms. So I am going to, from there, kind of the big picture, I'm going to jump into the technology and what do we do with it. So there are 3 modules, and I'll try to make it not as tedious and boring here, but risk assessment. So patient comes in, which patients are at high risk, which patients are at low risk, so you can focus your resources on the high-risk patients. First step. Second step is, what do you do with these patients? How do you prioritize your patient list as a case manager in the hospital? And the third is, then what? What do you do with these patients? How do you communicate with the post-acute care agencies, such as a nursing home, where a patient might not need to go after the surgery is completed, and they couldn't go home because they wouldn't be able to take care of themselves, or for other recovery reasons they couldn't be at home. It could be as simple as they don't have a caregiver at home to take care of them. It could be as simple as that. So there are socioeconomic factors that we put into our algorithm to figure out which patients are at a higher risk. And so Post-Care Connect, the third module, is all about that electronic communication and referral with the post-care acute care agency, but also keeping track of these patients when they are at home or at a home care, with a home care agency or at a nursing home. So, kind of completing the loop where the hospitals now get the ability to track these patients after they're discharged from the hospital. So, as a company, we are very excited about this change of attitude in the industry where now quality is everything, and it's not about just the episodic care where you just take care of the patient and they go home and something bad happens, they come back and you get paid for it. So it is all driven around quality, and that's where we want to be. The other thing we are really helping the industry do, which is around the accountable care models, which really means if the hospitals are now accountable for these patients, overall health, whether they're in the hospital or not, then how does the hospital make sure that the nursing home is doing what they were supposed to do? How does the hospital make sure that the home care agency is really taking care of this patient? So what we help with is reducing lead time around these discharges. So, from a communication perspective. So if you say on day 2, this patient is definitely going to nursing home, and we are going to make this connection with that nursing home at day 2 of admission as opposed to day 7 when they're going to get discharged. This is great for the nursing home because a lot of them work on a contingent staffing models, and if they can say, yeah, I know how many patients are coming in through the door in the next 5, 7, 8 days, they can operationally be more efficient and end of the day save a lot of money. But even more importantly, they can provide SLAs to the hospital around quality metrics that are not possible today. So we are providing that platform. So there is the post-acute care component of the platform that allows the nursing home to be able to get information on these patients and be able to track these patients. So again, I'm going to jump into the technology part. It's a software as a service, and we put the tools in the hands of the users in whatever platform they are. A minute. Okay. So it's agile. We can quickly enable a provider to use our product. It's interoperable with various electronic health record systems and allows single sign-on through your current set of credentials, and also allows for any kind of integration with your current set of systems. And a scalability. All tiers of the software are independently scalable, and on our side, gradual investment in infrastructure is enabled. On the hospital side, they don't need to procure a hardware or anything like that. I mean, just regular benefits of a software as a service platform. There's stuff about software architecture. I'm running low on my time here, but we work on the Microsoft platform, .NET from a development perspective, and so I would appreciate if there are people here that work on that platform, have experience with it, come and talk to me after the presentations. And the biggest thing we bring to the market is the machine learning, predictive modeling, and the big data techniques to the healthcare industry to really help the decision makers at the front lines, the case managers, the nurses, to make good decisions with all the data sets that are available today, but also as we collect when we work with the hospital, feeding it through a decision engine and helping them with decision support. I mean, that's really the big aha in this platform, and you don't have to do anything. It's just all that data is being collected real time and being fed through a decision engine. I talked a little bit about development process. It's agile methodology, and we do great work with 1 to 2 week sprints at the most, sometimes 4 weeks depending on the size of the chunk. Yes, absolutely, great question. So it's about who are our customers currently and what the results been like. So we are currently live at 8 hospitals across the country, I would say. There are 5 Philadelphia hospitals and 3 in Houston, Texas, 3 hospitals at UPenn, the UPHS systems, and 2 of the Thomas Jefferson hospitals. And the results have been fantastic. Just with the ability to risk stratify patients at admission, we are able to show, because of the way the behaviors change based on the perception of risk, we have been able to show a 35% all-cause across the hospital reduction in readmission at UPHS, and a similar results at other hospitals as well. Yes, and that's the question is this specific to a certain set of diseases, or is it disease agnostic? And the answer is it is disease agnostic. The core algorithm that we took and improved upon was built based on no disease diagnosis codes. The biggest problem there is that by the time you code, figure out what the diagnosis is, in a lot of cases it's too late from a care coordination perspective, so it really helps.
Platform?
Yeah, the question is, do we put our system in the workflow, or do they have to hop out onto another platform to get outside of their workflow to do it? One of the points that I mentioned was in the workflow. So with my 12 years of experience doing enterprise integration, especially on the healthcare side, we know all EHR systems and how to integrate with them. So we are really good with that. And we embed the questions in the EHR system. We have code snippets that you can drop in to have our questionnaire in there and all that. So yeah, very much in the workflow.
Our presenters this evening.
Thank you.